Good morning. We're going to go ahead and start on time. We have a very interesting lecture ahead of us, and we'll wear red ribbons. I think you know why. I would also like to announce that today we have additional site connected to us. We have the ARC. There they are. So this is exciting. We have more people coming up and joining us for grand rounds. Hi, guys. And I'm happy to introduce Dr. Natalia Rachmanina, who is an associate professor of pediatrics at George Washington University and the director of the Special Immunology Pediatric HIV program here at Children's National. She's a member of Division of their Infectious Disease and has been working at Children's since 2002. Natalia received her MD degree at People's Friendship University in Moscow, Russia. I'm very happy about that. And obtained her PhD degree at their Erasmus University in the Netherlands. Graduate of 2 pediatric residency programs, one in Russia and one in the United States. She is board certified in pediatric and HIV medicine. Dr. Rachmanina focuses her interest on diagnosis and treatment of the HIV infection in children and adolescents. She is a successful clinical researcher and principal investigator of several NIH-funded studies. She has developed joint projects with Johns Hopkins University, Universities of California and San Diego and Los Angeles, CDC, and DC Department of Health. Natalia is also involved in several important international collaborations, including the Netherlands, Russia, and Canada, and is an elect chair of the HIV Drugs Committee at the International Association for Therapeutic Drug Monitoring and Clinical Toxicity. In recent years, Dr. Rachmanina has become one of the leaders in promoting routine HIV screening of adolescents and youth in the healthcare settings, particularly pediatric emergency departments. Her talk today will focus on development of such program here at Children's National. Please welcome Dr. Natalia Rachmanina.
Well, thank you very much for giving me that opportunity to speak today. Oh, I apologize, I already messed up something. If you can, this bottle, yes, hold on just a second, let me, sorry. Tomorrow is an AIDS Day, and that's fine. And we have tradition of presenting the grand rounds dedicated to the HIV, AIDS around the world and focusing on what is our hospital doing. And I know on purpose want you to pay attention to the 5 ribbons, red ribbons, which we will distribute around that are listed on the top. And you see the hands protecting the world from HIV, and each hand has 5 fingers. And what I have done in the grand rounds today, and I'm very honored to have Dr. Newman present today. On November 17, Dr. Newman addressed the CRI and have asked us 5 questions during the presentation of his vision of children's future. And with Dr. Newman's permission and courtesy, I have used the 5 questions, 5 fingers, 5 ribbons throughout my talk to try to link to what we are doing to these questions and try to link it to our vision of HIV and AIDS. I will start, and I want you to travel with me on a very global picture. We will start with the world, and we'll gradually land our travel here at Children's National. You all know that the world continues to suffer from HIV as one of the major diseases affecting modern humanity. About 33.3 million people are infected in the world with HIV. Among those are children. 2.5 million children are suffering from this disease, living with it. And what most dramatic is that we keep losing about 260,000 children younger than 15 years of age each year in the world to this disease. When we will be looking at the statistics, and these are the latest statistics by WHO from 2009, they're available on the website, and you can all achieve them. I didn't put any references, as you can see in my slides, and I'll be happy to share them. About 7,000 infections occur each day, and that's approximately, by the estimates of 2010, it's approximately the same number. And among those 7,000, 1,000 are children under 15 years of age. That means that by the end of our grand rounds today, 41 children will be infected with this disease, will be born under the age of 15. And 6,000 out of the 7,000 are adults aged 15 and older, but we all know we don't call them quite adults here in our pediatric world at the age of 15. And 51% of them are women who will be delivering children, who will be potential source of mother-to-child transmission. And 41% of those are young people 15 to 24 years of age. And this is a scope where we're still looking at them as our patients. As I told you, I want you to be traveling with me from the world global picture down to our country and to the city where we are. And here you can see obviously the facts, and I'm not going to focus on that. You do know that the majority of infection is affecting sub-Saharan Africa, very closely followed by South and Southeast Asia. North America comprises about 70,000 new cases a year, and we'll talk about of the majority coming out of the United States. And you can see the red star being our city there. So what's going on in the United States? In the United States, we don't see much dynamic in the new cases, despite all the prophylactic and the drug availability, tremendous campaign on education, outreach campaigns. We continue to see the same, approximately same amount of new HIV cases per year. And you can see estimated in 2006, 48,648,100. In 2009. What's worrisome when you look at the dynamics and the proportion of who gets infected, we can see that in 2009 there was 21% increase in HIV incidence among the younger generation, 13 to 29 years of age, and among those was also a very sharp increase of 34% among young men who have sex with men. HIV disease in this country disproportionately affects African American population. African Americans comprise 14% of the whole U.S. population, but if you look at the cohort of HIV infected people in this country, this is 44%. And you can see that African American men are significantly at a higher risk of being infected with HIV. They are followed by the Hispanic men at 39.9 per 100,000 persons, and very closely followed by African American women. In the U.S., someone gets infected with HIV every 9.5 minutes. That means, we are not on the scale of the world, but that means that by the end of this grand rounds, 1 hour talk, about 6 people will be infected with HIV in this country. And you can see how high is the proportion of the younger generation suffering from that condition. Estimated 1.1 to 1.2. Yesterday there was a release for NIAID by Anthony Fauci. It's 1.2 estimated now, 0.1 million up from previous estimate. Americans are living with HIV, but what's most worrisome that more than 20% of people who are living today with HIV are not aware that they are infected. In 2006, the landmark document was released by CDC. These were recommendations which were updated, and I will go with you over details from the previous 2001 version, and they were led by Dr. Bernard Branson, who is now a good friend of children's and is quite a support to our program here. This was a truly important document that for the first time spoke about very new principles in screening for HIV in the United States. The major points are outlined here. First of all, it was proposed to move in from the concept of opt-in screening. When you come to someone and you tell him, I would like to test you for HIV, I would like to know if you have it, to opt-out screening. When the patient is notified, we are doing screen on everybody, and we are going to do it on you unless you opt out. The second serious recommendation in this new set of recommendations by CDC was to propose to do annual screening in all persons at high risk. And being high risk is definition that you live in the area where the prevalence of infection is more than 1%. The CDC also recommended to give up on the separate written consent, which was at the time required by many states in the United States. In 2006, however, DC did not require already the written consent. You can test for HIV in the District of Columbia, and you do not need to obtain a written consent. So we were a bit ahead of the game. But some neighboring states like Virginia and Maryland at that time still required a written consent. CDC highly advised to give up the concept of written consent, and they also advised to let forego the prevention counseling, just realizing that when we want to screen a very large number of people, it's not going to be feasible to provide a very detailed prevention counseling prior as a part of diagnostic screening in the healthcare settings. So I'll move on the first question by Kurt, which was asked at the CRI meeting. And I'll just read the slide for you. What does thinking bigger and thinking differently mean to you, Children's National and CRI? And I was attending the meeting by the WebEx, so I didn't have a chance to voice in, so I take this opportunity to say To me, it means that children and adolescents around the world are all HIV free. And I don't think I'm the only one with that vision. I think this vision is shared very widely. Just 2 weeks ago, Hillary Clinton gave a talk at NIH, and in her talk, she proposed to create a generation of young people free of HIV. So it's truly widely shared by HIV providers. It means that Children's National is a recognized a national and international leader in the clinical care and the prevention of HIV. And it means that our Children's Research Institute is a recognized national and international leader in the pediatric and adolescent HIV. And I will talk to you about what we have done within this particular program and how this can be lining up along that vision line. WHO defines HIV epidemic as any area where prevalence of HIV is more than 1%. You can see that as of December 2009, in the District of Columbia, we had 3.2% prevalence. Just to put it on the world map to you, I want you to look at the Nigeria, Africa, for example, 3.4% prevalence. So we clearly live in the area of the HIV epidemic by World Health Organization definition. As around the country, HIV disproportionately affects Black residents of the DC. 4.7% of all Black residents of DC are living with HIV. 7.1% of all Black men in DC are living with HIV, and every Black woman in the DC is 14 times more likely to have HIV than any white woman. What's interesting in DC that the heterosexual transmission continues to prevail and slightly even over, very close, but slightly over male to sex with male transmission in DC. So that clearly puts us at a higher risk in general cohort and more community impact. In 2006, right directly following the CDC guidelines, DC Department of Health received a very significant funding from CDC to promote routine HIV screening in the city. And it started with GW Emergency Department. Dr. Jeremy Brown was very, very active in moving this forward, extended to Harvard University and followed by Unity Healthcare. We also started doing it here, and I do know the Dr. D'Angelo program in Burgess Clinic has been doing routine screening in the clinic, outpatient clinic settings since approximately the same time. The screening test was proposed to be used OraQuick Advanced. This is an oral fluid which uses just a swab in the mouth, rapid antibody HIV test, and these tests were purchased by Department of Health with CDC funds from the company and distributed at no cost at every emergency department, every healthcare settings that was providing the screening. This can be administered as a point-of-care test. The results of the screening are available in 20 minutes. You have 20 minutes window to read your results, so you can have them as soon as 20 minutes after swab in the mouth of the patient to up to 40 minutes. Its sensitivity and specificity, as you can see, for point-of-care testing lab is quite high. It's actually, I believe it's high even than close to the pregnancy test. So when you look at OraQuick Advanced, everything comes in a package, and I won't take too much of your time, but just to walk you through that, you have a swab. This is a flat pad that's used on the inside the mouth of the patient. There is a reusable test. You have a developer solution where you put the test after you swipe the patient's mouth, and you do have a collection loop because the same test can be used for the blood. So where's Children's National with all that process when we know what's being unveiled in the city? Well, Children's Nationals clearly have a very good history of providing incredible work with HIV infected and exposed community in DC. We have more than 20 years experience in providing these services. We have two major clinical programs, one under leadership of Dr. D'Angelo, which is a Burgess Adolescent HIV program, and a pediatric program associated with special immunology program, which I run. We have an incredible support from William Barnes, who I'm welcome to see in the audience today, with the federal money, Ryan White grant, the one that you hear about, that supports multiple support services in the hospital for many years. We also do see a lot of adolescents, 13 years and older, in our emergency departments here, and actually this is combined numbers. When we just had ED here on this campus, we saw approximately 1,000 to 1,200 patients per month, and now with addition of UMC, we are getting close to the 1,200 and 1,500 adolescent visits per month. Children's National also has this established concept of safety net for the community, children, and youth. And Dr. Teach, as you know, runs a very efficient program, Impact Asthma, where ED actually serves as a safety net, catching the patients with a chronic condition. So the concept of looking at ED as a place which doesn't only address the acute issue for which the child or adolescents are presented here, but it now enables us to catch up a general community health problem has been already developed here. So these are all very positive elements for us to start thinking to the next question. And the next question is, what have you and your team done in the past years that is an example of thinking bigger and thinking differently? And I believe what we have started doing and which we are now taking to a different level is indeed an example of thinking bigger and thinking differently. In 2008, just 2 years after the CDC guidelines and initiation, within 2 years of initiation of testing of the adults in the area, we first conducted a survey of the parents and guardians. We wanted to know whether this concept can be brought up in our hospital. In 2009, following the survey, we initiated the screening at Sheikh Zayed campus, and in 2010, immediately following the opening of our emergency department in UMC, we started the testing there. So what did our survey show? Obviously, when you bring some new initiative like that, the people get anxious. The people say, what if our patients don't like it? So we said, okay, we will do it step by step. And in 2008, we surveyed more than 400 pairs of guardians and adolescents in ED. Each one of them had confidential settings to answer the questions. And we asked them certain questions about virtual tests. At that point, we were not offering the test. We were asking them, what if we were to offer the test? What would you say? And the nice thing was that we saw that our patient population and guardians are saying that's a good idea. If you offer the test, we will be doing that. What we found out, I don't think will be surprised to anybody who has had a teenage child, that the majority of guardians wanted to hear the result first. When we asked them, do you want us to come and tell you the result? And what did the teenagers say? They wanted to know the results first, right? Kind of not surprised, but it helped us greatly to design our algorithm. This is just a part of the screening algorithm, but I bring it to you to show you how the survey helped us to address the issue of teenager confidentiality. Again, this is just part of the algorithm, which is much more complex and takes into consideration the patient medical condition, etc. But from the point of view of guardian and patient relationship, what we do, the patient is triaged if he is over 13 years of age. He is considered to be eligible for the screening unless there are certain medical conditions. If the patient is not, he's given appropriate care. And then both patient and guardian are informed that the ED is offering the screening test. At that point, we ask them whether they accept it and we can move forward. Pretty much we ask them that whether they do not opt out. And if the parent and guardian are informed, if they accept the test, that the results will be delivered to the patient first. So even at the beginning, the parent and the guardian both have to accept the terms of disclosure of the result, with the guardian accepting that we will come first, tell the results to the teenager, and with the teenager's permission, we will deliver results to the guardian. So you can see how that survey helped us to develop that component. And by the DC law, we can test teenagers without the presence of the guardian in emergency department because it's considered a sexually transmitted disease. You do not need parental consent if the teenager presents by himself. So what happened after? After that survey, within 2008, we have an incredible team of people. And I will just show you main names. And I on purpose put this picture here because there are many other names who are not able to list all during the time of the talk. But this is just the people, the key personnel, the key people at Children's who all got together, created one multidisciplinary team, which allowed us to use this initiative forward. And clearly, laboratory medicine, quality assurance program, CLIA waiver, all the aspects of the JCO survey, all of it was addressed prior to the start of the screening. Incredible team in emergency department, Dr. James Chamberlain, Stephen T. Jennifer Fritz, who was then a lead head nursing person. We couldn't have done it without Dr. D'Angelo's experience and willingness to take the referrals and to serve as on-call service for anybody who is positive. Dr. William Barr's support was absolutely crucial. Our youth connections, legal regulatory. We had to speak with Department of Health about reporting our negative individuals. Are we going to disclose the date of birth and things like that? Was an incredible help as well, and team from special immunology. So what happened next? Between November 2010 and February 2009, we were able to train in Oracle how to administer and certify 120 nursing personnel in our emergency department at this campus here. And then in March 2009, we launched our first test, which was performed purely by ED personnel. At that point, we had designated ED personnel performing the screening after the physician order in the back room. In the March 2010, we received our first funding from Department of Health to start up that screening. We started with very good intention. You saw how much work was put, but we all know real life scenario is different from what you want to happen. And as soon as we started March, April, the first month, we just started building capacity, and I will show you. But in May, we had a big outbreak of H1N1 flu. And at the same time, ED between May and June was transitioning to electronic medical records. So the nurses were clearly very busy. And what we saw is tremendous drop in the testing numbers. So we clearly realized we cannot move forward unless we have some additional support. At that point, it was very rational to keep pushing nursing staff, which was overwhelmed, to perform the task of routine screening. So with support of Dr. Williams-Barnes and Ryan White funding, we were able to have 2 full-time positions of designated testers, which at the time Benitra Johnson, who is here in the audience today, and Miharika Sate started, and later on Jennifer Sinkfeld took on. And as a result of our continued effort, in October 2009, we received our second DOH funding in the amount of $50,000. Now, this is what happened between March 2009 through September 2010. And that's exactly what I described to you. We started building capacity in the first 2 months, and we had a significant drop in our screening due to related factors we just discussed with you. See what happens when we have 2 additional dedicated testers placed on AD, and the numbers really went high. There was some temporary decrease over summer months due to the staffing issues. But I want to pay your attention to here, January 2010, when we really made 2 very significant steps. First of them was adding another half-time support with the DOH funding support. But one very crucial transition was made by ED staff to accommodate the routine screening. We were able to develop an algorithm for the triage nursing order. So we moved away from testers being dependent on finding the physician and physician placing the order in the system to the triage nurse generating the order for the test right at the time when the patient was processed to go to emergency department, which gave the testers the green light to approach them and continue to do testing. As you can see, the result of this combined changes and the flexibility of algorithm has led to very significant increase and significant capture rates of our population. We also ran the analysis to see what's happening when we don't offer the testing, why we are not doing it. We took the cohort of all 13 years and older where the test was not offered, and we tried to see why it's not happening. And what we saw there was that fairly good proportion was deferred by ED staff, and we didn't ask for the reason. I mean, our forms do not record the reason. We just know that ED staff deferred. We saw that the lack of time was still a very significant barrier to ED nursing, quite understandable in our very busy ED. We saw that unstable medical condition took a very big chunk, and the rest of the factors played a smaller role. However, what's important here is that recently tested, we can see that our numbers of recently testing starts growing, and we also can see that we do see in our ED a lot of HIV-infected kids. About 2% of individuals who already identified as HIV positive. Not many pediatric EDs around the country have such a high proportion of HIV-infected adolescents. This is a very busy slide. I don't want to spend too much time here, except I want you to walk with me through these numbers. These are patients seen in ED, and we break it down by 6 months time period, starting March 2009 to August, and then going forward through August of this year. These are the numbers, total numbers of the patients seen in this time period. These are patients approached. And you can see that we start capturing only 10% of patients, go up to 25, and we're somewhere in the 30th percentile, which is not bad because very few pediatric EDs in around the country which tried this. St. Louis Pediatric ED, New Jersey Pediatric ED, they capture rates only about 20%. So this is, and Le Bonheur Hospital in Memphis, the only published report of doing this in ED, pediatric ED, is also around 22%. So I just want to say that. And I also want you to pay attention to that number, estimated prevalence, because by the end of the talk, we will return to estimated prevalence at our main campus. In 2010, we are moving to opening the second emergency department just a year ago at United Medical Center. United Medical Center has a large adult pediatric ED, which at the time was already running the screening program. And we immediately, prior to the opening of the ED, started the United Medical Center team, which includes all the people listed here, and started developing the algorithms for the screening there. Differently from our Sheikh Zayed campus here, we decided to move there without funded support. And that was not our choice. It was the choice of the personnel in ED. The team there said, we're a community-based hospital. We have different pace than the main ED. Let us try to do with our own resources. So it's a completely different mode of function. And in October 2010, as soon as the ED opened, they immediately initiated the screening. And due to that initiative, we were able to renew our $50,000 funding from Department of Health, but we also got another funding by Department of Health of $75,000 to expand our program to United Medical Center. And this is what happened over the last 12 months. This is the last year report. You can see that the Children's National Sheikh Zayed campus continues to perform well with some really, really incredibly good months. And then you can see how the capacity in lighter orange, how the capacity of United Medical Center is gradually growing up. I do want to bring your attention here. We had a big interruption of the testing here from Department of Health. I'll shortly be speaking about that. But you can see that despite that, our testing continued to go on. So when you look at the last 12 months combined data from Sheikh Zayed campus and the United Medical campus, you can see that we generally capture a fairly good proportion of the population between both campuses. We're staying in our 30th percentile. But you can also see that estimated prevalence has grown to 0.13%. And do please remember that number with me as well as we move forward. So now we have created a certain competition because we have a program that is funded through Ryan White with testers run by the dedicated personnel. And we have a program run by our nursing and ED tech staff. And you can see that in the first 6 months of implementation, the main campus, Sheikh Zayed campus here, is leading. But you can see that the emergency department and United Medical Center is actually doing a fantastic job. And they're capturing out of eligible patients, these are the number of those approached for screening, their capture rate is significantly higher. And we see an incredibly healthy, very, very fun competition going on between two campuses in the ability to run this program. In the recent developments, in July 2011, as you saw that blue arrow on the previous slides, when we looked with you at the bars, Department of Health has informed us that there was a decision made, which was not consulted with providers around the city. Decision was made to transition from the oral fluid test to the finger prick test. That's obviously created a great concern for us. And what we decided to do is immediately to combine some evidence-based approach to that. So immediately following after release of this letter, in following months, we conducted a survey of our adolescents. We only asked these adolescents who were already tested. Those who already were going for the oral test, we asked them whether they would still accept the test, whether they would not opt out of the test if the test was administered as a finger prick. And you can see that the 33% of our teenagers who were going for the test said they wouldn't do that. And generally, I was quite surprised myself, and we've been talking it over years with Dr. Teach and Dr. Chamberlain. We only draw the blood on 30–35% of the patients, which would mean that in a very large proportion of the patients, we would have to administer finger prick only solely for the purpose of routine HIV screening. We also surveyed the ED staff in September of this year, and we asked 55 ED staff members, 30 of them nurses, what did they think about the transition of technology from the oral fluid to the finger prick. And you can see here that the 96% of our providers have saw that the finger prick had the potential to very greatly, the majority, and somewhat decrease the acceptance of the test by the teenagers. And you could also see that a large majority of our providers clearly say that they preferred to stay with the oral fluid test. As a result of this survey, with the support of multiple key players here, the ED staff, Dr. Jim Chamberlain, Dr. Stephen Teach, William Barnes, D'Angelo, primarily with the support of Jacqueline Barnes and Timothy Jones, we contacted Department of Health and we appealed about the decision, particularly of us being a pain-free campus for children. And I'm very pleased to tell you that we were granted the permission to continue using oral fluid test and as a main HIV screening test in our emergency department. We did agree to give it a try on the Clearview, which is a blood test only on those patients who already have on the blood draw, and we're currently looking into the performance of this program. What's more important to show you that starting this on time and moving along with the city, we're able to be somewhat ahead of the game. In October 2011, just a month ago, the Department of Health has issued a very important letter. There is a mandate from the mayor and Department of Health to move toward billing for the test. Actually, at that time, it's quite problematic, in my opinion, because right now we're getting all the probes for free from Department of Health. But there is a very big push, and there is now legislation prepared that's going to enforce that every insurer, and this is in this letter partially, that every insurer who provides coverage in the district area has to pay for routine screening testing, including emergency department settings. We started working on the billing already a year ago, and we are very much ahead of the game, though we still have not implemented the billing in this institution. With the billing, there are certain provisions that you need to work out. First of all, we are really advocating for make it a facility charge. We don't want the parents of the teenager who came to emergency department alone and undergone routine HIV screening to question him in case there is an issue of confidentiality when he sees an itemized bill for the HIV test done in emergency department. So that's, has been our very big drive. But recovery of the cost is very important. The kit test, the one that I showed you in the market, is only about $12. But you have a lot of personal time going into that. So far, with incredible support of our lab, Karen Lacey, Dr. Lubin, we have our lab personnel entering in electronic medical record of each patient the result of point-of-care test, and it's done in kind. We want to come up with a mechanism which will compensate the time of all the personnel involved in that procedure. And finally, once we transition to the billing, the choice of the test, more reliable, the cost, the choice, will lay with us. We will no longer be dependent on anybody choosing any particular test for us. We could choose the one that will be the most appropriate for our institution, and that will be the most cost efficient. And again, the incredible team of people who are all on the board, who are working with us through the hospital-based specialty, who are working with us on the initiative of transitioning this toward the billing procedure. And we're really hoping and looking forward to introduce the billing mechanism and to win ourselves eventually from the grant support in 2012. I move to the question 3 by Kurt, and that one is research. And obviously, those of you who know me more close know I wear clinical and research hats very combined, and I couldn't have gone without that question. And how current research, how can you apply this concept? We definitely, in this sense, want not only carry this on as a clinical initiative, but we see great opportunities to expand this into very sustainable and independent research. So clearly looking at routine HIV screening in healthcare settings. We are already running from the first day when we started the program in emergency department. We started the program looking into this as a research project. We are collecting the data prospectively on all the variables that are listed on the slide. I won't repeat all of them. You can see there are multiple, trying to see and learn how it's done. The name of my talk was How to Do It Right. Nobody in the CDC guidelines has stated how to deal with adolescents. Nobody has addressed the pediatric emergency department. And today, there is only one paper from Children's Hospital in Memphis, Le Bonheur, which really talks about rather implementation of the program, but doesn't truly analyze all the play factors in it. We looked at our teenagers, and one of the aspects of research, it's already not a feasibility, it's to look what's happening with the teenagers. Why are they doing the testing, or why they are declining? And it's very interesting that you can see that the number of teenagers who have been recently tested negative for HIV, who say, I don't want the test because I just recently had the test, is quite significant in our population. It's about 1/3. We also have a substantial amount of groups that says they don't believe they're at risk. But what's interesting, only 10%, somewhere around 10% of the teenagers 13 years and older report not being sexually active as a reason of declining the test. I bet you if you ask their parents, there would be a much higher percentage. And then you can see some other reasons: too sick, too tired, and not willing to wait, and other small factors. We looked at our data, and to date we have some very interesting findings which we are now in process of presenting in a published form. We do see that black adolescents generally are more likely to accept screening as a non-black adolescents. Obviously, with the community so heavily disproportionately affected, that could be the reason. What's interesting for us that at UMC-ED, the patients appear to accept screening significantly better than they do here, and that might be also to do with the location of the hospital and where the hospital hospital is always a novelty of the program there. We have to look deeper in that. We also see that the patients residing outside of DC, those of our patients who come from suburban Maryland and Virginia, they're significantly more likely to refuse to opt out of the test than the residents of DC, and that can do something with the campaign of education and the perception of epidemic within the city. The mean acuity clearly is less emergent in patients accepted screening, and I think it makes perfect sense because we analyze the acuity index in the patients. And then one interesting finding, which for us always the question, does it matter when the kid is there with a guardian? And what we are seeing is that the patients under the care of the guardian are less likely to accept the test than patients without guardian. So those teens who come alone appear to accept the test more. And we also see that the older they get, for each year age of difference, the presence of the guardian matters more. And that's all we want to take into consideration when developing the future program direction. This research has supported not only our program in terms of improving the quality and development, but I listed for you some of the abstracts we presented based on this program. And what I did, I highlighted the names of the students at GW and the residents and the fellows who took part of it. So I just want to share how one clinical initiative in the hospital can lead not only to the clinical initiative that allowed us to test more than 9,000 youth in our emergency department in the last 2 years, but also allows other young people who are in training in GW and here to grow in their careers. So the two PS abstracts in 2009 and 2010. In 2010, we were presented and were featured at the National Summit of HIV diagnosis here in National Harbor, Maryland, as one of the best pediatric sites in the country. And finally, this summer at the International AIDS meeting in Rome, we had an honor of oral and poster presentation on that subject. As a summary, research around this project has brought us two REACH projects which are completed. Two students with GW School of Public Health who got the MPH degrees awarded. One student currently in the audience, welcome Chim. And then since 2009, a total of 3 grants. These are implementation grants with a total funding of approximately $300,000, and we have 3 manuscripts in the progress. So moving to the question number 4, which asks about the bigger and thinking quite different. And I do think that we could become the first pediatric hospital to expand routine screening to inpatient services, and we already started this work with support of Dr. David Stockwell and others, and we could become the first hospital to transition to routine screening as a standard of care, where we will just build in our clinical function independent of grant funding. I want to show you some very interesting data from CDC, which was showed by Dr. Branson recently during our meeting here in DC. Look at this. This is an overall United States picture of CDC expanding testing in United States. And what you can see is between 2007 2009, EDs, inpatient screening going on, urgent care, STD clinics, correction facilities, substance abuse clinics, TB clinics, community health centers, and others. What you can see here that clearly HIV tests are administered by far more in emergency department, even compared to the areas and clinics and services which you would think target very high-risk population. But you also can see that the percentage of positive individuals revealed through the routine screening is significantly higher coming from the emergency department. In summer of this year, 2011, August, New England Journal of Medicine published a truly very nice breakthrough study from HIV Prevention Trials Network study 052. It was very highlighted during the meeting in Rome. This study, which is frequently brought by Dr. Fauci during his presentations now, has shown that early initiation of treatment of HIV, even in those individuals who do not meet treatment criteria for their own health, significantly decreases the transmission of HIV in the community. Actually, significantly is not enough. It's more than 95%. So we do know that if we identify an individual, even if he is not at that stage where we need to treat him, if we treat him, that we will decrease the spread in the community by more than 95%. As a result of this finding, and along with this work, which results were already preliminary available over last years, HTPN launched another very important study, which is called TLC+, Treatment Linkage to Care. And this study is going to be conducted in only 2 large metropolitan areas, in Bronx, New York, and DC. And they will have 4 comparison sites in Chicago, Houston, Miami, and Philadelphia. And the comparison sites were chosen by the prevalence of HIV and the similarities in patient population. But I'm very proud to say that we are the only pediatric site in the whole network between Bronx and DC, in particular our ED program. And you can see this is a very large grant. I don't want to take your time. It also has a component of paying the patients for having virological suppression, has 40 sites here. But expanded HIV testing has only 14 sites, and our emergency department program is one of them. And we received more than $400,000 funding for that program, which we initiated in February, and it's to last for 3 years. So question 5, as we're near the end, is pretend you have unlimited resources and name a possible big idea. And my big idea, obviously related to that program right now, is that we develop a national algorithm of how to integrate the routine HIV screening into standard care at the pediatric hospital, including pediatric emergency department and outpatient pediatric clinics. In October of this year, just a month ago, there is a published new guidelines with the authorship of the leading people from CDC and NIH on the adolescent and HIV screening. And these guidelines really bring a landmark, and I'm very happy to see them coming out, because though our publications is not there, which I think is a big miss, which we are trying to catch up now, but I have had several discussions with the people who were developing these guidelines, and our program is well known. What is very important to realize how in time we worked along with the thinking on the national level about the HIV routine screening. The AAP policy clearly states that a routine screening needs to be offered to all adolescents, at least once by 16 or 18 years of age in healthcare settings where the prevalence is more than 0.1%. And please do remember, when I was showing you the graphs and tables, I kept pointing out our prevalence rate between our emergency department campuses right now is 0.13%. So we clearly fall in this category. And in the areas of lower community HIV prevalence, thinking about our outreach programs and different locations, routine HIV testing encouraged for all sexually active adolescents. So that means you need to know whether adolescent is sexually active or not, and it's not a very easily addressable issue always. But this is really walking along with our thinking, and I'm very happy to see how we are ahead of the game here as well. So in conclusions, routine HIV opt-out rapid oral screening is accepted by majority of adolescents seen in pediatric ED. We have proven that through research, to our clinical existence, through our concept. It's also accepted by the guardians when they are there. Implementation of screening clearly requires multi-level support. It requires support from ED tech, from the person who is at the door emergency department. You want my opinion, even from security guys there, because they do get asked, is your ED offering HIV screening testing out? To all the top level of hospital leadership. You need to be flexible. You need to continuously adapt algorithms. You saw we started with one concept. We moved to the supported dedicated personnel. We now run 2 different algorithms of screening, 2 different ED settings. It clearly requires continuous reassessment of your work. And I'm a strong believer that transition to billing procedure and the ED staff performing the test, including our Sheikh Zayed campus, are crucial to fully integrate this program into the standard of care in any facility. I would like to finish by 2 slides with pictures. A year ago, during National Summit of HIV screening testing, which was attended by representative of White House Surgeon General, this is Dr. Everett Koop. Those of you who are younger and don't know him, he was a Surgeon General in the United States between 1982 and 1989 during the time of outbreak of HIV epidemic under the Reagan administration, which makes it very challenging. He also just happens, Dr. Newman, is a pediatric surgeon. I'm pretty sure you know Chuck and his achievements, and has a very strong stand on the pediatric health throughout his tenure as a Surgeon General. This man was 95 years old. It was a remarkable and moving experience to hear him present for an hour an excellent talk about the years in the White House, about what took him to deliver to each single American household a letter about HIV, to appease the public, to give information to the public, because at that stage he was under a lot of directives on the Reagan administration not to release information to the public, and there was a tremendous degree of anxiety. So this man has done an incredible service to this nation. And there is now established award in his honor. It's called Everett Koop HIV Public Health Leadership Award, and it was presented to Dr. Koop a year ago at the National Summit by Dr. Anthony Fauci. And you can see we had a wonderful time talking about our hospital with Dr. Koop and talking about our program. And from the left to right, it's Nicole Messenger, who is now a coordinator for the HPTN TLC study. You recognize me there. Benitra Johnson, who is one of our testers in emergency department, has done a fantastic job, and Jennifer Sinkfeld. And we really were very, very humbled by having Dr. Koop saying very distinctive words in honor of our hospital. Well, just a year after, very recently, Dr. Fauci and our program was invited to attend the ceremony in the Capitol Hill, received the second Dr. Koop Annual Award for his work at HIV. And Dr. Fauci has presented some really wonderful remarks in October, but nevertheless, for closing my talk, I chose his remarks from June of 2010, and I really want to finish by those saying that routine HIV screening is central to ending the HIV/AIDS epidemic. Every medical provider should think about screening the patient 13 years and older. It should become part of our routine assessment. And knowing one's status is vitally important to the individual in protecting the broader public health in this nation. And I congratulate you with the coming World AIDS Day tomorrow. I'll be happy to answer the questions, but I do want to inform you that Infectious Disease Department supports a small reception in Minneapolis in honor of CNMC staff who made this possible. Again, we tested in 2 years over 9,000 youth. I don't even speak right now, and I could do the whole special talk of what public service we are doing by doing it, because we are raising a new generation of people who do believe routine HIV testing is part of their life. These kids are asking for the test. They are growing up thinking and knowing that's part of normal health care approach. And we are very proud to be part of the city initiative. And I'll finish with that, and any questions, any comments, I'll be happy to take. Thank you.
Okay, the microphone is working.
Adela, thank you for a wonderful presentation. Can you explain why the blood test was, you didn't give the rationale. It seems like when you look at the specificity and sensitivity, there's not a good reason unless that was better. So what was the rationale for a government agency to implement that without asking the people whether that would work or not?
That's an excellent question, Max. We were cited rationale as being the cost. We were told that the cost consideration played a major role in it. The Clearview test is available at $7 a probe, though this is currently federal money. I must tell you that the cost consideration, in our opinion, is not well thought of, because as you saw, the package contains everything. With a Clearview, you get the Lancet, which we were told, and I don't think even all the packages have Lancet, but the Lancet we were told needs to be replaced. So you would have to acquire the Lancet in addition. It doesn't contain alcohol pad, it doesn't contain the bandage, and you need to have a sharp disposables associated with it. So it would be less cost to Department of Health, it would impose a greater cost on us, in addition to everything else. But we were cited as the main rationale of the cost. I believe, Max, to tell the truth, that there is a certain movement on the blood test in the terms of adult facilities. And that's, I think, what played the role. Certain centers around the country were very well networked, and even in adult EDs around the country who are doing that. Some emergency departments, like in Texas, they do the blood test, and they batch them, and they run them in thousands, particularly in the high in Hispanic areas where the epidemic is high in these areas. They batch them. The problems there, for example, we looked at this algorithm. You cannot catch the patient. The patient leaves the ED. They don't have results available at the time of the contact with the patient and things. So my feeling is that the blood test was somewhat, the idea was somewhat moved from by CDC, but then taken out of Department of Health with a cost consideration rationale. Any other questions?
Thank you, Natala. I just wanted to also say that I appreciated the way you included information about the process of conducting the research, almost in a QI kind of perspective, because I think that's really important in terms of translational research. And also, I commend you for including the trainees in this important research.
Natala, fantastic presentation and terrific work for our institution. Why do you think our prevalence in the emergency room is so much lower than the prevalence that the city is citing for adolescents and young adults? They're citing a prevalence somewhere between 1.1 and 0.9%. Why are we lower?
Well, we are 0.1, and they're saying 1.1. I think it's because they are looking at the older cohort and they're throwing the data from 16 to 19. We never broke it down that much by age. I also think they are aiding the prevalence from the very specific high-risk centers where they're conducting community research, because I think they're taking this data out of the overall testing in the city, and a lot of it is done in targeted young gay men clubs and things like that. And I think that our biggest concern is the population we're still not capturing. With all that said, how well we've done, my biggest question is where is this 70% that we're still not capturing, and whether we need to increase our ability, how to make it more doable, how to make it more attractive, how to capture, because I do believe that maybe if we had the percentage that very consistently says no, whether it's there. Another thing that I think we have space to grow is we looked recently at some preliminary data on our STD screening, which starts mounting, and it is now urine screen. And we do realize that not always do we couple with STD screening with HIV screening. So we can find cohorts of patients, teenagers who had STD urine screen, but they haven't got routine HIV screening. And those kids have STD, so we know they are the risk factor, and we know they had unprotected sex. So I still think the combination of factors, one of them is DC reporting high numbers because of targeted screening, partially, though it's called routine, but it's really targeted. And second, that we still have space to grow to increase our capture rate, and then maybe our even epidemiological numbers would go higher when we do that.
Yeah, the AAP recommendations are somewhat helpful.
Yes.
But there's a paper going to come out in the archives of pediatrics and adolescent medicine sometime within the next couple months that's going to cite the CDC figures that show of kids who had sexually transmitted infections, only 37% had HIV testing. And so we're still really way behind the curve in terms of extending testing to even kids who are clearly at risk, never mind routine testing. So the question I ask is, when will routine testing truly be routine?
I agree with you fully. And what we are doing as a first step, Larry, we're now working on the algorithm where you could not order STD urine screen in our emergency department without doing HIV. It has to be coupled. If you are doing STD screen, if your mind has been crossed, the child might have chlamydia, gonorrhea, anything you are screening on this test, you should be doing HIV test along with that. So our next step is to achieve at least that all the routine STD screening is linked directly to that. There's one great initiative, ICC4 Morrison in the audience, that came out recently, and we're working on it actually with one of our ID fellows leading it. The concept of a doctor teacher's work absolutely marvelous with in terms of impact asthma. What we were thinking to do, and Dr. Teach and I submitted a CDC grant in April. We've got very good pink sheets, but we didn't get the money, which is always very disappointing. But we have proposed the concept of STD ED clinics. Our belief is at that point, looking and working with ED population of teenagers, that the teenager is much more likely to return to ED, where he had a positive screen for gonorrhea, anything else, to just window, and probably more likely to bring the partners rather than venture to the specific separate clinic or go in particular to the STD clinic. And I must praise Sephora came out to us just about a month ago, or 2 months ago now, and the UMC emergency department is started very realistically looking with one of the infectious disease fellow, very interested to take on the role along with adolescent program. And I do know you guys are talking about having satellite clinic there, having that ED window clinic where the kids who had urine, remember with urine STD screen, they walk out of ED, they don't know the results. You have to bring them somewhere back to get the treatment. And if you missed on HIV screen, then you have to do HIV screening if STD is present for sure, then not even the screening. So we are currently looking at the concept of creating a similar to the impact ED clinic for the STD. And definitely what you are saying is moving it forward and making sure that's always accounted for HIV is of crucial importance. Yes, Patricia.
Great presentation.
Thanks.
Do you have any numbers on vertical transmission in the last year?
Yes, we did, and I didn't want to bother you, but the prevalence was 0.1% in this campus and 0.17% between two. Over 9,000 totals screened. I don't know if Nikki is there. I have a total number of positives. It's not that high. You can do the math. I mean, 0.17% between both CDs. So, but I must tell you what also has been great in our program, we have not had, and that's due to Ryan White support and use programs run by Larry and William Barnes, we haven't had any loss to follow-up. This is the biggest issue. When you talk to teenager at the time when you do the test, you don't know whether they gave even the right information to contact them, especially if they're there alone. To establish the trust, to be able to build a rapport by which they will definitely give you the correct cell number where you can reach them. So the way the algorithm is set up right now, anybody who is positive, the youth connection personnel gets down to ED. They physically walk the kid here in this campus to adolescent program. They let them know where to be. They establish, liaison that they come in. UMC is a little bit more problematic because the kids there frequently don't have any means of transportation. So we actually work there with Howard University program. They have a patient navigator and they have ID clinic. They offer the services, but we are waiting for our satellite there to be open because we have seen some patients from UMC reluctant to come here. They seriously just a pure transportation issues. This is a very poor part of town, and a lot of teenagers there, they walk by feet. A lot of patients in adult ED, when you spend time there, you will see a lot of patients do walk by feet to the hospital. So we haven't had a single follow-up to any complete loss to follow-up to any of the positive individuals. We link them all to care, and we were able to bring them back, which can be quite challenging. So that we consider that a success even without small numbers. Well, please do, go ahead.
Well, thank you for your brilliant presentation, and I'm excited and that you are leading the way, and that Children's National is leading the way on this very serious, and as you laid out at the beginning, a constant threat to the world, to the United States, and then right here at home. And I guess I'm a little egotistical that I liked your the way you framed my questions, and also honored one of the real heroes of American medicine, Dr. C. Everett Koop, who was or is a pediatric surgeon, was chief of pediatric surgery for years and surgeon-in-chief at the Children's Hospital of Philadelphia, was a mentor to our own Marty Eichelberger, and as you said, courageously changed the way people thought about HIV and AIDS when he was going against the political grain and his own political grain as a staunch conservative, some would say right-wing, in the Reagan administration to change people's attitudes. You're showing that same courage and inspiration to all of us to continue this good fight. I listened and saw some of the things. We don't have unlimited resources, but we do have resources, and we need to use them wisely and take on these challenges. So thank you, Natala.
Thank you, Dr. Newman. I just want to tell you that this year when Dr. Koop was given a award to Dr.